so that people who are not able to be here today are able to access the content, and that content will be up on our website in the coming weeks. So that's great. We'd also like to take some photos or screenshots throughout the event. So if you're shy, you could turn your camera on to dark or black screen, but we would love to see your beautiful faces. So I do encourage people to keep their cameras up. You know, even if you're having lunch, that's absolutely fine. We love to see people's faces and see who is actually out there listening in our community. So I do encourage that, but please do know that there will be some photos taken throughout the day. So in terms of social media, we've got a hashtag for today. So our hashtag is hashtag NIRD 2022. So if you're going to perhaps share with people in your social media about today's event or some of the conversations that come from today, we'd really love you to use that that hashtag on both like Instagram or Facebook and so forth, maybe even Twitter, if there's people out there that do that, because we'd really love the content to be able to, you know, be shared and talked about continuing after today. So I do encourage you to do that for us. We'll put that hashtag in the chat box, won't we, Alicia? Yeah, pop that in there. Yeah, so we have put everyone on mute. So sorry to the little dogs that were barking earlier, but we had to put you guys on mute. But yeah, we'll ask people to keep on mute just because there is so many people in the room. But there will be lots of opportunities to participate throughout the day. So if you've got questions or comments that you'd like to add into the chat box, that's great. And then we will have question time and be able to do that. And later on today, we'll be able to take some questions as well verbally if people would like to do that. I think encouraging questions is really important. And Laura and Alicia will assist me too if I miss any of those in the chat there. So yeah, if you're looking at speakers when they're presenting, it's really great to switch over to speaker view rather than the gallery view. So you'll be able to see who's presenting, and you can just do that up the top. I think on the right, there's switch to speaker view. And just also wanting to acknowledge that we want to recognise that some of the topics we will talk about today, they might be hard topics for some people. And we do like to remind people that there is always somewhere to reach out and talk about things if they get difficult for you. So places such as Lifeline can always be contacted for crisis support. And us here at Muscular Dystrophy New South Wales, we are also available business hours for information and support about conditions or muscular dystrophy issues that you might like to talk about. So yeah, we'll put some contact numbers in the chat as well so that people realise that there's always someone to reach out to. Oh, that's a lot of housekeeping we got through, but let's get going. I think we get on with our jam-packed program so don't run out of time. Everyone who knows me knows I talk too much, so I'll have to MC myself in and stop talking. But we're kicking off this afternoon with a new friend in our community, Fiona Mitchell. Fiona is the newly appointed CEO of the Muscular Dystrophy Foundation Australia. And then after that, we'll be having our keynote presentations from Dr. Amanda Piper and also from Dr. Dominic Fitzgerald, who's both here from hospitals across Sydney. And they're going to be talking about respiratory issues, very important. And then we'll head into our plenary address from Professor Craig Munns, and he's going to focus on bone health. And we'll also hear from a really experienced physio, Karen Herbert, who works at the Sydney Children's Hospital. Then we'll have our break, and we're really excited today to have an entertainer who is a person with lived experience of muscular dystrophy. So we'll introduce him later on. And after that break, we'll have an update from the Australian Neuromuscular Disease Registry. Lots of long words. Robin will be coming back to talk to us about what's new with the registry. And then we'll be breaking into our 3 topical sessions. So we've got breakout sessions. One's called What's New with Myotonic. One's called Dealing with Changes in NMCs. And there's another one called How Do I Optimize Mobility for My Child? So we'll introduce those speakers as well later on today. And most of you will have chosen the session that you would like to be in, and it should automatically pop up for you, but don't worry if it doesn't, you'll be able to choose which session you'd like to go into. And I like to think of the highlight of the day as right at the end, we save the best till last, and we'll have our lived experience panel. So for a few years now, we've been really pleased to be able to present some members of our community who will be talking to you guys all about their lives and experiences. And, you know, we all know how valuable lived experience is. So we've got 4 young leaders in our community. We've got Jack Bailey, Jamison Leeson, Kate Thomas, and Julie Dong, and they'll be coming along to speak to us about what they're up to. So let's get started. That's huge, isn't it? Big agenda. So I'd like to introduce Fiona Mitchell from the Muscular Dystrophy Foundation of Australia. Fiona has over 20 years of experience in the not-for-profit sector, and she's worked across policy, regulatory, and program management domains in the health sector. I also believe she has been working at the Pharmaceutical Guild in the ACT. So she's a current board member of the Eating Disorders Families of Australia, and has recently been appointed to the Governing Council of the Australian Eating Disorders Research and Translation Centre. I told you there was lots of big words today. Fiona holds a biomedical degree and a Master's of Business Law. So she's a very smart lady, and she's here to meet us all and introduce herself to the community and tell us what MDFA is up to. So could you all please welcome Fiona. Hi, Fiona.
Thank you for that warm welcome, Carolyn. I might share my screen and
yes,
I can get this to work.
Yeah, and we know you have a PowerPoint because you said that'll help us in a 5-minute slot.
Let's see if I can be clever.
Yes, we all test our technical skills on these days, don't we? Oh, you've got it working. Well done.
First go. So you can see that?
Yep.
Yeah.
Yep.
Okay. I just need to get it onto mine. Give me 1 second. That's okay. All right. Okay, never mind. I'm just having trouble with my, that'll work to scroll through. Okay, I'll get going because I know, Carolyn, you'll probably keep me to time anyway. I've only got 5 minutes. So as per the introduction from Carolyn, I've only recently been appointed to my role at MDFA. So I really appreciate the opportunity to be able to come along today and just share a really brief overview of MDFA and have an opportunity to connect with everyone. So who are we? MDFA, we're the national peak body for Australia's neuromuscular community, and our members are our state and territory-based organisations. And then we have representatives from each of those state and territory-based organisations that sit on an MDF executive committee. And that is a collaborative forum, and we meet monthly, and that allows us to share ideas and work together on national projects. And our primary role involves advocating, and we do that for improved health and social and economic outcomes, facilitating and collaboration and providing industry leadership, influencing a national research agenda, and leading strategic national initiatives. Wrong way. And look, a lovely example of one of the strategic national initiatives that's been developed by MDFA and its member bodies is the Loop, which some of you may be familiar with. The Loop is a digital resource that's hosted by MDFA. And as I mentioned, it was developed as a very collaborative project by all the muscular dystrophy organisations in WA, New South Wales, Queensland, ACT and Tasmania. And the aim of that resource was to provide medical and health information to people and support the lifestyle and wellbeing needs of the community. But really importantly, I think that resource was built by the neuromuscular community for the neuromuscular community. So it's a great resource to find condition guides and get advice on just everyday life stuff. So I think if you haven't had an opportunity to look at the Loop as a resource, I'd really encourage you to have a bit of a look through that particular resource. So another key part of MDFA's role is to advocate for improved health outcomes. So some of the ways that we do that is by engaging with the federal government representatives on issues. We also might make submissions from time to time to government agencies and other regulatory bodies on behalf of our state and member organisations that represent those living with neuromuscular diseases. And we also strive to build strategic relationships with other like-minded organisations. For example, MDFA is a member of the Neurological Alliance of Australia, and we're also a member of the Accessible Product Design Alliance. And we work collaboratively with both of those organisations from time to time on opportunities to improve quality of life and on funding ideas to support research. So up on the screen here, I put a couple of examples of some of our advocacy and collaborative work over the past. One of the ones that is actually active at the moment, I think my cursor's working here, is this one here. It's called the Good, the Bad and the Hack campaign. And that's sort of a fun little campaign that's running at the moment for the month of October. And that's part of our work with the Accessible Design Alliance. And the aim of that campaign is to share experiences of different products, to raise awareness of accessible and inaccessible experiences, support others to make life easier, and help educate product and manufacturers about what they need to improve. You can find some information about that particular campaign and how to be involved on our website and Facebook page if you're interested. Some of our other advocacy work has included putting our position to the federal government with regards to the inequity between the NDIS and aged care systems for those aged over 65. And as I said before, MDF is also a member of the Neurological Alliance of Australia. Earlier this year, as part of that alliance, we developed a federal election commitment document that set out 4 key election issues, and they included investing in funding for medical research, ending age discrimination for NDIS eligibility, strengthening the NDIS, and ensuring equal access to assistive technology. So that work that we've started there, that continues both through our own efforts and through supporting alliances with other organisations who are advocating for similar systemic changes. So I promised I wouldn't talk for too long. So what's next? As I said, I've briefly touched on just some of the roles and recent work of MDFA. In the very near future, we're going to be looking to launch a refreshed website. So keep a lookout for that. That's where you'll be able to connect with us and find links to some of our advocacy work, and also find information on how we look to represent and support the community. So I just want to thank New South Wales, I think, for giving me the opportunity to speak today. It's been great being here today and connecting with everyone. I just want to say, look, feel free to reach out and connect with me following today's event. Enjoy the rest of the information and research day. Back over to you, Carolyn.
Thanks so much, Fiona. That's really great. We need a sort of little clap audio, don't we, so that everyone can clap you for that. So thank you so much, Fiona, for keeping it to time and for interesting stuff. I echo your comments about the loop. You know, often people are asking about, you know, has anyone done this, or has anyone tried that, or what do I do about this? And I always say to them, try the loop. You know, that's a national, you know, body where we can actually get like lots of peer support and advice from other people with lived experience. So that's a really great one. And it's also great to hear you guys working on the inequities for people who are not able to access the NDIS. That's a really common issue that comes up for people who missed out on their, you know, for age reasons, not being able to access the NDIS. So thank you so much, Fiona. That's wonderful. So let's move on to our first keynote speaker. We've got Dr. Amanda Piper here. I think I've seen her name in the chat, so that's great. There she is. Hi, Amanda. Hello. Wonderful to see you again. Thank you so much for coming today. I'll just introduce you while you set up your screen, and if we should just be able to make you a co-host so you can share your screen.
Okay.
So the topic we've asked Amanda to speak on, and it was a bit of a, I think it was a bit of a doozy of a topic we asked her to talk about. Little bit of a difference from last year, which is a good thing. We've asked her to speak about well-being in a COVID and everything else world. And we put in the and everything else when we started hearing about RSV virus and, you know, just the usual flu taking people down really badly this year, and pneumonia and things. So Dr. Amanda Piper is a senior physiotherapist from the Department of Respiratory and Sleep Medicine at RPA Hospital, Royal Prince Alfred in Sydney. She's been involved in the assessment and management of people with neuromuscular conditions for more than 25 years. She's an absolute legend. She's been involved in statewide and international guidelines around non-invasive ventilation. She knows, if she doesn't know anything about this topic, then no one does. So I'd like to introduce Amanda Piper. Could everybody please warmly welcome Amanda?
Okay. Hello, everyone. Thank you very much, Carolyn. And it's lovely to be here, and a real pity we can't see each other in person. But I think just before I start my talk, just some caveats. I'm not a medical doctor, so things like medications and that, I don't prescribe medications, and I'm currently no longer looking after the general, COVID wards or long COVID. But what I do is look after patients with breathing disorders, including those people who have neuromuscular conditions who may or may not have been contracted, COVID over the last couple of years. But I also did work on the COVID wards during, and particularly the Delta and the Omicron, providing respiratory support and oxygen to people who ended up in there. So I think, if we sort of go back where this all started, and there was
very quickly, so I can't really talk, but how can I help
Has
you?
Ladybird had her lunch drugs?
No.
Okay. So
right, I have to give that to her then.
we were really
Okay,
concerned about
right.
the impact of
It was
COVID
good.
on
I'm
people
in the
with
neuromuscular
conditions.
presentation now, but they're talking about COVID on people. So
Okay. And
Okay.
so part of that
I'll
was
okay
the
then.
increased risk of
Right.
contracting COVID in people with neuromuscular conditions. Would they be more, because of the comorbid conditions that often come along with a neuromuscular condition, would these individuals be at higher risk of developing more severe COVID and requiring hospitalization, ICU, and all that was associated with that? And of course, there was also huge concerns about the complications that arise in anybody potentially in anybody with COVID, that there can be some neuromuscular complications, things like almost like a Guillain-Barré type syndrome, where people can develop weakness, throughout, was being reported in some places. The fact that people lost taste and smell, it was sort of, thought to be related to some damage, to nerves. And certainly we do see people developing respiratory muscle weakness, and of course the overwhelming fatigue that a lot of people were reporting, particularly early on in this pandemic. So, there was certainly a lot of risk and risk mitigation in people with neuromuscular conditions. We felt that people might be more vulnerable to having more severe COVID, mainly because, for many people, their respiratory function was already reduced, particularly people who are on bi-level or non-invasive ventilation devices who already needed assistance with breathing. The fact that some neuromuscular conditions are also associated with swallowing and aspiration and, things going into their lungs. And even people who just had simple sleep apnea, there was a concern that sort of snoring and the aspiration that can occur with snoring may put people that who are just had obstructive sleep apnea more at risk of developing COVID, because they were more likely to be pulling those COVID viruses down into their lungs with in their saliva and with their postnasal drips. Particularly early on with COVID, the earlier versions of it, a lot of people had very thick secretions, which was going to be a real problem, we felt, with people who had neuromuscular conditions where their cough muscles were affected, or their cough coordination wasn't as good as what it should have been. And of course, other things like, some of these neuromuscular conditions have problems with, enlarged hearts and that. And of course, COVID could cause that kind of problem as well. So it's very hard, because neuromuscular conditions are there's so many different conditions that it's very hard to bring them all together just to see how many people were actually impacted by COVID. But looking through the literature, and you've got to remember with the literature, even though around COVID, it's been coming out very quickly, anything by the time it gets into the literature, we're talking about something that happened 12 months, 12 months earlier, 9 months earlier. So some of the studies, that are being published now looking at things that were happening really about 12 months ago. For instance, this study from Brazil looking at just over 350 patients with neuromuscular conditions in Brazil found that in this group that they were looking at, 25% were on some form of ventilatory support. And of those 363 people, 38 of them had a suspected infection. Now, of course, being Brazil, they didn't have quite the same access to rats and PCR that we had here in Australia. But 30 of them only, it was suspected that they actually had developed COVID. And in 35 of those, it was only mild disease and they didn't require hospitalization. So, again, many of our concerns about how vulnerable people with neuromuscular conditions might have been maybe didn't quite play out, fortunately, the way we thought. In this particular study where they were looking at people, they were reporting about 25% of their participants said that they had a change in sleep pattern, but I think that went across the board for everybody. Weight change in about 40%, and I can attest to that as well. And only about 2% of the individuals that they had in this study required an increased time on their ventilatory support. And there are a number of other small studies from Britain and Europe suggesting that the impact that COVID had on people with neuromuscular conditions was actually, in terms of health outcomes, was fairly low in terms of the infection rate and more severe outcomes requiring hospitalization and intensive care. Fortunately, much lower than what we first feared. There was a worldwide electronic survey of people with muscular dystrophy. And it is important to remember that these sorts of surveys, sometimes often there's a huge bias as to the sort of people who will actually go online and answer these. But they had about 1,200 participants, half of whom had facioscapular humeral dystrophy, and just under half had myotonic dystrophy. And they were asking people their experience with the pandemic about a year into the pandemic. And of those 1,200 participants, about 98 reported that they had had COVID, so about 10%. And of that, only about 1 in 10 required hospitalization, and only 2 needed ICU, and only 1 required invasive ventilation. And, the sorts of symptoms, most commonly as across the board, it was the fatigue and the muscle and body aches. And I think the other important thing about this study was just the recovery period. So in general, if you look over here on the right-hand side, about 50% said that they recovered and were back to what they felt pretty much normal within about 2 weeks. But very importantly, about 10%, 8 weeks down the track, were still saying they hadn't fully recovered back again. So some people, even now, COVID is often no worse than, they get a bit of a runny nose. Some people are, might be sick for a day or two and then feel pretty good. But for some people, it can be quite a prolonged recovery period, whether or not you've got a neuromuscular condition or not. I guess the other way of looking at it is the people who we felt might be most vulnerable were people who are already on ventilation. And this study out of Lane Fox in the UK were looking at people on ventilation who, passed away across 2020, and they had, based on earlier data, what the prediction for each month, how many people were likely to pass away on, they have a very large database of individuals who are on therapy, because it's one of the major ventilation services in the UK. And you can see this is from 2020, and you can see when COVID first hit, there was an increased number per month across that February, March and April period of more people passing away than what they had expected, but it very quickly went back down to within what was fairly typical for that particular service. And when they look specifically at people who either had rapidly progressive or slowly progressive neuromuscular conditions, the mortality rate of those people passing away in 2020 wasn't any different really to previous years. And in fact, where probably it was a higher rate of people dying were those individuals who were very overweight. And we know that COVID did seem to hit people who were overweight much harder, particularly in this. Remember, this was the very early stages of COVID, and COVID continues to change, and its impact changes every few months. But the impact of COVID really had a significant impact on clinical practice with our lockdown, how it changed, things like outpatient visits and hospital activity. And again, looking at things like in the UK, being able to even provide things as an inpatient like CPAP and non-invasive ventilation was very diminished, being able to bring patients into hospital. But like a lot of hospitals here in Australia, there were ways around it. We even went down, I can remember sitting out in my full PPE with somebody setting them up on non-invasive ventilation on a battery in a big open space. One of my colleagues went down and we transferred somebody from a simple ventilator to a life support ventilator in the back seat of the car, doing all the training there, because they weren't, nobody was allowed into the hospital because ventilation was considered an aerosol generating procedure. So we had to be fairly creative as to how we managed to continue therapies. But I think one of the really important things was the social and mental impact of, and a lot of people with and without neuromuscular conditions had a lot of anxiety about the virus, and also the impact of the lockdowns and just how that was going to affect their routine personal care. And again, in the study from the UK, the bigger the words, the more people sort of, voted, and things like anxiety, worry, scared, and health were very prominent features, particularly early on in the pandemic. But I think a lot of people with neuromuscular conditions are incredibly resilient. Like in this study, and it was Swiss, and it was only after a 2-month confinement period early on in the pandemic. But the prevalence of things like anxiety and depression was actually fairly low. Some people might have reported slightly more symptoms related to confinement, things like feeling short of breath or feeling fatigued. But basically, it didn't seem to affect how they were using their ventilatory support devices. But I think the important thing about this survey was that the complaints about isolation and lack of social contact were probably the most prevalent things that people were reporting, and that people with neuromuscular conditions really felt well supported by relatives and caregivers. But I think from a health professional point of view, what these individuals that were surveyed were saying was they felt a real lack of regular contact and information being provided by their, the healthcare professionals. And I think that's something that we need to take note of. And hopefully this kind of thing won't happen again, or not for another 100 years, but it is something that hopefully we'll be better prepared for next time round. So as we think about going through 2022 to 2023, you know, things are changing. You know, we don't need masks anymore. We don't have to isolate anymore. You know, it is important to remember things are very different now than what they were across the winter period and during that peak across January, February time when the Omicron really hit us. And even though we don't have to, necessarily, sort of do that sort of isolation isn't mandatory any longer, I think it is important that all of us have to look out for one another. And even when we're doing, you know, the rat tests, I think this is an interesting study from the US, and this was young athletes that they were studied. They sort of had them nice and in a confined space. And they were looking at people who, these students, and they were looking at them at day 7, and looking at their sort of rat tests, and over a quarter of them were still positive at day 7 after having contracted COVID, and 10% even on day 9. So that, you can still be spreading, spreading virus even after your 5, 7, 10 days in some instances. And it's not always people who are symptomatic. I think one of the big game changers that I've seen is the advent of the oral antivirals. Paxlovid is the one that we're using a lot, that we've seen used in our patients, and it certainly helps prevent high-risk people from being hospitalized and becoming very sick with the virus. But it's really important is to identify that you have got the virus and you need to take this medication within, it can be taken at home, but within 5 days of those symptom onset. So it's important to make sure whether or not you've got COVID and get yourself tested for it. And certainly we saw across that, that winter period, an increased number of prescriptions for this medication, the antivirals. I know a number of our patients that we see at RPA, sort of rang us, and we managed to get them onto therapy. And this is a medication that actually has 2 medications within it. One is an enzyme that actually stops the virus making more virus of itself. So that's why it's really important to take this medication early on to reduce that viral load so it can't sort of take over. And the other medication, it sort of boosts the level of that antivirus by stopping it being broken down in the liver. So it's not for everyone because it does have side effects. If you have to be careful other medications you might be on, particularly heart and blood thinners. It can cause, some allergic reactions, diarrhea and nausea. And there is some reports of rebound that people, when they stop getting it, then they get symptoms of COVID and they can test positive for COVID again, but usually the symptoms are quite mild after that. So I think when we're talking about, where we're going, we've got to think about, even though the virus is less aggressive than what it was a year ago, we still have to think about general respiratory health. And I think it certainly is something that has made us think about that. Hand washing where we can, being sensible about, social distancing and being all over strangers, wearing masks where it's appropriate. And I think it is important distinguishing if you've got symptoms, whether it's a cold or whether it's COVID. Rat tests are not good if you haven't got symptoms, but they are quite useful a few days into it to see whether or not you are still infectious. And while we're talking a lot about COVID, and, Carolyn brought it up, that we also have to think about flu and RSV and all those other things, particularly across, those winter periods that we, I think all of this has made us more aware of, what respiratory symptoms are and how to keep ourselves as safe from them and getting treatment as quickly as possible if we get either the flu or COVID. So I think, we're in a good place at the moment in general, because when we think about the general community, a lot of people in Australia are vaccinated and have been boosted. Or they've had previous infections. So there's a certain amount of general herd immunity out there. And there is this idea of variant adapted vaccines and boosters as well going into the future. We've got access to antivirals that seem very effective, at least for the current versions of the virus that we currently have. And the variants that we're seeing at the moment are not as severe as they were a year or two ago. But that means, people are still using some remote, therapies and medical care, but we're getting back to operation as normal. And we're seeing a lot more people in hospital with COVID rather than because of COVID, and the COVID's much milder. So I think we just have to be really sensible when we're out in big groups, and where possible, if we're doing things, trying to be as, in as open a space as we can where it's reasonable. And of course, thinking about if you have got symptoms or your family has got symptoms, sort of testing to make sure what you have so that you're not spreading it unnecessarily. So I think, finally, with COVID, we need to be alert, not alarmed, getting back to normal for mental health reasons, whether that's with family, getting out with our sporting activities, but just being very sensible as we go about it. Thank you very much.
Oh, Amanda, making lots of sense as always. Thank you so much. That was fantastic. And we might hold questions. If you could hold on the line while we have Dr. Fitzgerald present, and then come to general questions about all of those things, if that's okay. Thank you so much, Amanda. Great. So I'd like to now introduce Dr. Dominic Fitzgerald. Thank you, Dr. Fitzgerald, if you'd like to get your screen ready while I give an introduction to you. You're a paediatric respiratory and sleep physician who works at Children's Hospital Westmead. So thank you so much for coming in today. Your main areas of work are with children with congenital structural lung diseases like neuromuscular conditions, cystic fibrosis, asthma, and other sleep disordered breathing. You've written a book as well. We'd love to see that. That's The Better Health for Our Children, a guide for parents. I think that's a must-have for all the parents out there. And you were awarded a Churchill Fellowship to look at that, and you've specialised in some support for families of children with cystic fibrosis. You're also the editor-in-chief of the Paediatric Respiratory Review, and you've published over 220 articles. So you know what you're talking about, Professor. Thank you so much. I will introduce Dominic Fitzgerald. If we've got your presentation up, that'd be great.
Thank you very much, Carol.
Oh, ready to go.
I think it's on the screen. I'm being technically assisted by MDA New South Wales, so thank you very much. I'd like to acknowledge the opportunity to come and speak to the MD family in New South Wales and more broadly, and I thank you for that opportunity. Next slide, please. So the overview of what I'm going to talk today is about sort of optimising respiratory care. My focus is primarily children, as I'm a paediatric respiratory physician, but many of these things we talk about are relevant right across the age spectrum. I'm going to talk about basically muscle weakness, and the results of that, as you can see on the left-hand side of the screen, result in problems with the coordination of swallow, the bulbar muscles, the expiratory muscles for breathing, inspiratory muscles, and they have an impact upon how your upper airway functions. If you like, the neck muscles, leads to cough dysfunction, and if you like, difficulty breathing with smaller lung volumes and what we call ventilatory dysfunction or respiratory failure. A consequence of this can be recurrent infections, and they can start with bronchitis and lead to pneumonia. Another consequence of, if you like, having reduced lung function is that it's more obvious during sleep rather than during wakefulness for all of us. And so you can get what is called sleep disordered breathing, and that can happen in sleep before it happens during the daytime as part of respiratory failure. So I'm going to talk in general terms about muscles very briefly. I'm going to talk about minimizing the risks of infection, carrying on from a lot of good advice that Amanda has just kindly shared with us. I'm going to talk about chest wall problems with some scoliosis, and as well as the consequences of being above a healthy weight. talk about swallow and aspiration, weak cough and clearing secretions, and some practical advice on what can be done, also with recurrent infections and respiratory failure leading on to the use of bi-level or non-invasive ventilation. Thank you. So normal breathing sort of relies on a good drive to breathe. So that's the brain telling your chest to move up and down. You need a strong chest wall and ideally a straight spine. You need open airways and a strong cough, and you need an efficient transfer of oxygen from the air sacs into the blood, as well as removing carbon dioxide from the blood into the air sacs to breathe out. And as well, dare I have to say this as a respiratory physician, I have to acknowledge the value of the heart in the chest cavity. You need a strong heart to pump oxygen-rich blood around the body and to the muscles, brain, and other organs. So then if you think on the left-hand side, you've got the drive from the brain to breathe, and you've got a balancing act between how strong your muscles are and the load, if you like, that those muscles have to move. And that can be influenced by weight as well as the volume of air in the lungs. And you can get an underbreathing called alveolar hypoventilation. Thank you. So how do muscles help breathing? Well, there are three main groups. There's the diaphragm, which keeps going whether you're awake or asleep, intercostal muscles and accessory muscles, particularly the neck muscles, and the muscles of the abdomen. Thank you. So the diaphragm, this is mainly used for breathing, for breathing in, that's inspiration. When the diaphragm contracts, and as you know, that's the muscle between the chest and the abdomen, it pushes the abdominal wall outwards and increases the abdominal pressure. This lifts the rib cage upwards. It generates a negative pressure in space between the lungs and the chest wall, and this allows the lungs to expand. Air comes in, oxygen transfers then into the blood vessels and goes off to the body, and carbon dioxide will come out as we breathe out. Next slide, please. So we talk about the muscles between the ribs, or the intercostal muscles, and the accessory or the neck muscles. And these are the accessory muscles are very important for inspiration. And these are the ones at the top of the neck and the strong muscles at the top of the chest wall, including the scalenes of the neck and the trapezius muscles. Thank you. So the abdominal muscles, and these are mainly for breathing out, and these include the strong tummy muscles, the vertical one, the rectus abdominis, then there's the transverse across the tummy, and there's also the internal and external oblique. So there's three different directions, if you like, and all these muscles help with breathing, and they, if you like, help you breathe out. They lead to the passive recoil of the lungs after you've had a big breath in, and especially during sleep and forceful breathing, they can be used. They also, to just a little extent, help with breathing in by lengthening the actual diaphragm muscle, reducing the curve with which the diaphragm is placed, and this increases its strength. So in summary, muscles are very important for breathing. And when you have weak muscles, it will affect how you breathe in and you breathe out. And that is generally first seen during sleep. So if you like, sleep, and particularly dreaming or REM, rapid eye movement sleep, is a window to the future. And in pediatrics, we rely on that because it's a physiological test of how you're breathing and how you're going before people can do cooperative tests such as lung function testing, which really won't begin until school age. Thank you. So how do we minimize the risk of getting sick? And Amanda has touched on this. So if we just basically, if you think generally from the COVID-19 precautions, and you can apply it to RSV, influenza, or anything else. So that's simple hand hygiene, and that's activities of everyday living, as well as in the workplace or the schoolyard for children or preschool centres. Having the routine vaccinations, keeping them up to date, having boosters, particularly for whooping cough, as well as having pneumovax for pneumococcal vaccine. An annual flu shot is really, really important, and the government is very good in providing this at reduced cost, certainly for children. And I think that certainly during the pandemic was extended to adults. I think it likely that the flu shot will be even more heavily influenced, as it is really a cost-effective investment by government. And it may well be a hybrid as a COVID-19 and flu shot. And there are people now doing trials working on those hybrid annual sort of vaccines. I think the other thing is to avoid close contact with people with respiratory symptoms. All those raves that everybody goes to, the dance parties, the massive protest marches in the street, concerts, wherever you are and whatever you're doing, if people, you take precautions, you wear a mask in closed spaces, despite what perhaps the more economically driven advice has come from government. And I think that's indoor settings where you can't always control things, and even on flights, I think. And if you notice, there was some tension when the announcement was made by the COAG meeting and the premiers suggesting that mask restrictions will be relieved. But I think the general medical community, as also highlighted by Amanda, would suggest it's appropriate. That's great. Thanks. Stay there. No, move on. Thanks. So once you've got an infection and you get more respiratory secretions in your airways, if you've got weaker muscles and a weakened cough, it can be hard to clear that. So sometimes people more generally have, with extra pooling of secretions, saliva, if you like, in the mouth, which will have a medication to help dry up secretions. And those two, or the three options you've got, are one called glycopyrrolate, which can be taken orally or through a gastrostomy, hyacinth patches, which are used for seasickness, and they're patches that you put just behind your ear. They last for 3 days and they can reduce secretions. And another one we use occasionally in children is nebulized Atrovent, which is an asthma medication. But that's less effective, but sometimes can be useful as well. Another thing to focus on is about clearing airway secretions. And so extrapolated from experience with people with cystic fibrosis, we use nebulized concentrated salt water. It's called hypertonic saline. Young children, we use 3%. Under the age of 2. In children 2 and above, we use 6%. And there are some, and adults will use 6 or 7%, depending on what's available. But there's essentially no real difference between 6 and 7%. This is given often with physiotherapy or exercise. We use positive expiratory pressure, or PEP. So bubble PEP for young children under 5, and PEP masks after breathing in, or combo PEP as it's known for school-aged children and adults, to not only loosen secretions with the salt water, but to use the positive expiratory pressure to help cough up secretions. And for people whose cough is weaker, there are cough assist machines which have been superb in actually helping people to breathe and move secretions. If you read the literature, they're used certainly above 2 years of age, but there's evidence even in late infancy where they can be of some benefit. Of course, in addition to this, particularly with people who have got more progressive lung disease with lower lung function, have developed sleep disordered breathing, they'll require non-invasive support or bilevel. And bilevel itself can partly be thought of as passive physiotherapy during sleep. And Amanda will certainly appreciate that, I'm sure. Thank you. Next slide. So muscle weakness. And so on the right-hand side of the panel, you see what's called the Gowers maneuver. This is a boy with Duchenne muscular dystrophy getting up off the floor. So there are many causes of muscle weakness, but there's certainly a common pathway with lower muscle tone, different posture, and shallow breathing, which can compromise your gas exchange. That means you can have low oxygen and high carbon dioxide, and you are prone with reduced lung function to getting repeated chest infections. So it's very important to be alert as to lung function for people with neuromuscular weakness. And as I said, we can't always do it with cooperative measures till young people are of school age. And some still aren't always able to concentrate and focus and do that. This is why we rely, for example, on a history of what is going on, physical examination, as well as the use of overnight oxygen levels and more particularly sleep studies to give us that information. Thank you. So the chest wall problems we can get, an S-shaped bend in the spine called scoliosis, and this is very common in neuromuscular conditions. On the right-hand side, you see somebody who has got a curve in the spine, which extends, as you can see, in the lower chest area down to, with a compensatory curve in the pelvic area. And they measure a thing called the Cobb's angle, and it's a way of measuring the progress of the bend in the spine. Now, having a bend in the spine is actually a very minor bend, is quite common. In fact, up to 1% of boys and up to 10% of girls can have a very mild scoliosis without any neuromuscular disease. However, if you do have neuromuscular disease, both boys and girls, you can develop asymmetry of positioning. It can be initially postural or reversible, but then does, in many cases, become permanent. The consequence of a severe bend in the spine is reduced lung function. It can lead to a torsion of your airways, which will not always be open to clear mucus. You can get recurring infections, low lung function, or restrictive lung disease, where you'll require some support, particularly during sleep, with, if you like, less petrol in your tank, with less oxygen in your lungs. And if you do progress to a certain point, you will be offered surgery, and that generally would be a Cobb angle of around 80 to 100 degrees, together with symptoms and very low lung function. The importance is that if you correct the scoliosis, you will slow the rate of loss of lung function. And scoliosis often accelerates during the prepubertal and pubertal growth spurt. So it needs to be monitored with X-rays, lung function testing, and as well as sleep studies in the pediatric sphere. Thank you. So another thing that can contribute to reduced lung function or restrictive lung disease is being above a healthy weight. And this is common for people who have reduced mobility, who are prescribed oral corticosteroids to reduce the inflammation in the muscle problems, such as with Duchenne muscular dystrophy. They can also run in the genes. There can be a family disposition. The consequences are, as I mentioned, reduced chest wall movement, which reduces the volume of air that sits in the lungs. And this will compromise how much air comes in and out every minute, called your maximum voluntary ventilation. As well as in sleep, you can not only underbreathe, but you can also have obstructive sleep apnea, if you like, where the neck muscles become heavier with fat around them, and the neck muscles, which do take a bit of a break in sleep, particularly REM sleep for all of us, become further compromised with excessive weight around the neck muscles. The consequences of this are low oxygen and high carbon dioxide, type 1 and type 2 respiratory failure, obstructive sleep apnea and or hypoventilation, and the need for non-invasive support, such as bi-level therapy, which gives you a breathing in pressure, a breathing out pressure, and a rate to maintain and optimize gas exchange. Next slide, please. So the clearance of secretions. Now, we all produce mucus in our airways. It's usually thin, clear, and white. And when we get viral infections, we get extra secretions that we have, and we cough up. Part of the mechanism for clearing those secretions from our airways are small hairs, if you like, that you notice in the inside of your nose, but they also, similar cells are in the airways, in the medium and smaller size breathing tubes as well, called the bronchi. And these little hairs work like an escalator to move mucus out of the bottom of the lungs and up through the windpipe for us to cough up. It relies on patency or opening of the airways, but also these little cilia to move well. And the little cilia, little hairs, don't move well with infection. And also if you take up other habits such as smoking, that also compromises the ability to clear mucus and debris out of your lungs. And so to treat that, we use nebulized salt water and airway clearance techniques the physios will share with you, as you know. Next slide. So the increased secretions with viral infections lead to a vicious cycle. You can get increased mucus retention, clearing the mucus. And mucus at body temperature is a great culture medium for a secondary bacterial infection to give you bronchitis and inflammation, and that can lead to lung damage over time. Exposure to tobacco smoke, which is particularly important for young children who aren't mobile enough to get away. This is where family members smoke inside the home or inside the cars, which is a particular problem. As well as this, you have not only infection, but if you have food, particularly milk and oral secretion, saliva going down the wrong way into your airways, this just makes the situation worse. Thank you. So the coordination, you'll have problems with the pooling of secretions in your mouth. Sometimes, we all do this to a certain extent, if you drink too quickly, you can cough and splutter with liquids, which is a protective mechanism for the voice box and your airways trying to clear secretions that shouldn't be there. It may result in noisy breathing and difficulty in breathing after feeding. And this is particularly with younger children. The speech, to investigate this, you can have the assistance of speech pathologists who are very good at observing people feed and listening for signs. They can do some extra tests, a contrast study called a modified barium swallow, where you can swallow liquid or sometimes foods that have contrast in it to look at the coordination of how the muscles are working. And indeed, you can have a further assessment with a camera put down not only to your airway, but also into the food tube, the esophagus, to look at anatomical factors. And in children, that's done under a general anaesthetic. The management would be to facilitate airway clearance, thicken feeds, at sometimes short-term, particularly with children with intercurrent illnesses, to use a tube through the nose into the stomach or a nasogastric tube short-term, or if there was a long-term problem whereby the coordination of swallow was not going to improve with more severe neuromuscular conditions, a gastrostomy or a PEG with if you like, a tube straight into the stomach is used, and that bypasses the swallow and reduces the risk greatly of aspirating into your lungs damage and causing lung damage. Thank you. So a weak cough. Results from weaker muscles and results in reduced lung volumes, whereby as a predisposing factor, you can't actually cough to expel liquids that are in those lungs properly. So this results in the impaired clearance of secretions, and you present really with a rattly chest or a cold that tends to linger and give you a moist cough, which is often bronchitis. So for some children, adults, most people are over a viral infection with a bit of a chesty cough within 7 to 10 days. But with bronchitis, it may well last for 2 or 3 weeks with a rattly chest and a cough that continues. If it gets worse, it may continue with pneumonia and hospitalizations. We manage it, as I said, by using nebulized salt water, physiotherapy techniques, and a cough assist machine where appropriate. Thank you. So bronchitis, if you like, follows a viral infection. It's a wet cough that lingers. You sound rattly, particularly if young children when they're cuddled. Fevers are uncommon. And when you go and see the doctor says, oh, you've got a cough, but your chest is clear. Well, don't be misled. You still can have an infection despite having a clear chest. If you were to do some imaging, the chest X-ray would tend to show lower lung volumes, but not a localized area of what we call consolidation or pneumonia. And it's treated with airway clearance, physio, salt water, and cough assist, and sometimes courses of antibiotics because you've got a secondary bacterial infection in that mucus that's laying around in the airways. If you look at some imaging for people who have had CT scans, and the CT scan is not a routine test you would do, but using the opportunity to see what you would see if it was there to understand what's going on, you see the yellow arrow there pointing to what are thickened airway walls, which are, if you like, a bit like if you bite your cheek, you can imagine it swells up a bit, you get swelling of the lining of the walls and some extra mucus that you can't see on the imaging with inflammation that's lying within those walls. And on the other panel, just to the left of that, you can see those thickened airway walls going from a large airway just near where the airway is divided to the right main bronchus. And you can see that sort of tram track appearance of the large airway heading toward the periphery of the lung. Thank you. So pneumonia. So this often follows viral infections as well. You get a secondary bacterial infection, you get a moist cough, you tend to get fever, you become short of breath, you feel unwell, you have reduced appetite, and you get localized changes, usually crackles or reduced air entry when you listen with the stethoscope. And on a chest X-ray, as you see there on the right-hand side, you can see that triangular white wedge that is there in the right lung field and reduced lung volume on the right-hand side compared to the left with a normal-sized heart. And that's where you would hear the local signs of, if you like, fluid-filled spaces with infection within the air sacs of that area of the lung. It is treated with antibiotics, and it may need intravenous antibiotics if you're very sick, oral antibiotics, oxygen, non-invasive support, or if you're really sick, invasive ventilation in the intensive care setting. Thank you. So a sleep study, and this is respiratory failure, and this is a sleep study is used in children with neuromuscular disease as an early screening tool. And we do this on babies right through to children in the teenage years and young people, and obviously through adulthood. The advantage of a sleep study is it doesn't require cooperation in order to get information about gas exchange. There are no blood tests or no needles or blood tests. We do these in children. In adults, they tend to do a blood test. The parents and carer would be with the child the whole time. You come in about 5 or 6 o'clock in the evening and you stay till 6 o'clock the next morning. We put a whole lot of leads on you, sticky dots using ECG type leads on your chest and your tummy, one above one eye, one below the other eye, and a small tube under the nose to measure airflow through the nose. Sometimes extra dots on your chin to measure chin activity, and 4 in your hair to measure electrical activity. All those leads, usually about 15 or 16 of them, get pulled back into a ponytail. And in young children, it takes about 30 to 45 minutes to put those leads on. We also measure oxygen with a peg that sits over the finger called an oximeter, and heart rate double check through that. And we can measure carbon dioxide through the skin with a probe that sits on top of the chest wall. And then a small aspect of measurement, and this is oxygen and carbon dioxide levels you see on the right-hand side of the slide, Above in the top part of the panel, you see the oxygen percentage, and you see this is a low baseline. A normal baseline would average 95% and above, and you see the baseline here is sitting around 90%. And you see there are periodic dips, and here 2 large dips that you see going down, sitting in the 80s for periods of about 20 minutes. And this is cycling into what is rapid eye movement, or REM sleep. And it's also associated not only with low oxygen, but you see in the trace below, the carbon dioxide as measured increases, and it goes up from its baseline of around 50 to 60. So it's a change of about 10, which persists. And when you come out of the REM sleep into other sleep or wakefulness, you see that the carbon dioxide normalizes again. And when you go back into REM sleep, the problem recurs. And so this would be someone who's got respiratory failure and would benefit from extra expansion of the lung, help with breathing with non-invasive support or bilevel therapy. We use the sleep studies to titrate the most appropriate settings for the person. We can do things at the bedside to a certain extent, but we need to corroborate this with official information to get a bilevel machine, which would be funded by Enable in New South Wales. That may switch to NDIS in the coming years. There's some talk of that. But Enable to get a machine funded in children, you need 3 pieces of information: a diagnostic study, a titration study, and compliance with using the machine for at least 80% of the nights over a 4-week period. And we monitor kids with an annual sleep study. Thank you. Next slide. So in
Dominic,
sleep,
just to let you know, we've only got a little while left, so about less than 5 minutes. Is that
I think it's my second last slide.
terrific? Thank you.
Okay. So better sleep leads to better. Why do we treat this? Better sleep leads to improved gas exchange, better daytime performance, behavior, concentration, and school outcomes. We use it through non-invasive ventilation. Threshold, you can see there on the right-hand side, I'll skip, but basically low lung volumes and recurrent chest infections are the main indications. We use bilevel via a nasal mask. In children, we do not use nose and face masks because of the risk of vomiting and aspiration and inability to move the mask. And the cost is initially for families is about $500, and then Enable funds the machine for life for the person. And as I said, NDIS may take that over. Next slide. So in summary, I think respiratory and sleep breathing requires, and lung function requires regular review. It depends on the condition, the age, and respiratory problems. The minimum should be once a year and twice a year if you're on non-invasive ventilation in the pediatric world. Screening tests are lung function tests in school-age children and sleep studies. And I think optimizing lung function and sleep breathing quality is important for a quality of life and ultimately adds to life expectancy in terms of lived experience. And here's Jamison, who you'll hear from, I think, later on the panel, in her Australian gear at the Paralympics recently. So that's all I want to say. And thank you for the opportunity. I'm happy to answer any questions as is appropriate. Thank you, Karen.
Oh, Dr. Fitzgerald, wonderful advice. You've given everyone really lots of really great factual information about respiratory support, and I think that that's really, really useful. I'm a recent BiPAP convert myself, so I can attest to many years of resistance to looking at respiratory support, but I can attest to 2 full years of much better general health and much better feeling better as well as being medically better. So yeah, I thank you for that. And I think we should trust our medical experts for their advice, not our politicians on mask wearing and those sorts of things. So thank you very much both to Amanda and Dominic for your great advice today. Yeah, the fun of sleep studies. They're lots of fun, the sleep studies, aren't they? But a really good thing to note is you have less sleep studies once you go into respiratory support, because a lot of the data can be collected in your machine, which is really, really helpful. So yeah, I hope that helps anyone who needs to make a respiratory appointment, perhaps. And I also think I just wanted to comment, and there's a couple of questions in the chat, but I just wanted to comment that Amanda, when you said that the resilience of people with neuromuscular conditions, I think that's a really important point. And you know, one of our peers in our community said, I don't go out in the public and touch, you know, public items. I don't touch my mouth because I can't physically reach my mouth. So, you know, some of those little protective factors that you wouldn't actually think about were there during the heights of the COVID pandemic. And you know, we have been tending to isolate, I think, you know, more than the general public, and that's helped keep those infection numbers down for people with neuromuscular conditions. So yeah, I myself am also a survivor of COVID. So I did write an article in our we have a COVID collective on our peer collective. So there's lots of good, useful information in there for people about those antivirals that have come out now that have been very helpful. And I think the other point that you both made is about the heart and the importance of the heart in neuromuscular conditions. We don't always think that as the first thing. We think about mobility or respiratory, but I think the heart, you know, as you said, Dominic, is such an important part of that, and also the impact of COVID on hearts as well. So really, really great advice. There was some questions. I think Ellie's got a question in the chat. Ellie says that I haven't needed to take antivirals, but I'm concerned if I do, as I can't swallow the large pills. And I can't, yeah, that's right, Ellie. They are time release pills, so they cannot be crushed. Is my advice I've been given. Amanda, would you like to take that one?
Yeah, as I said, these antivirals aren't for everybody because they can have side effects, or, you know, there are reasons why people can't take them. And I think one of the things, and Dominic might have some more information on this, but, you know, there is this constant sort of looking at, you know, this has sort of started a whole lot of looking at different antivirals. So hopefully they'll have other things that are available in the near future, but I really haven't got any solution to that, because I think, you know, the Paxlovid is probably, you know, the best one that we've got, and it's got the best evidence at the moment that we've got in Australia. But they are certainly still looking at, there are other types of medications that are coming out that might be more suitable. But unfortunately, I think I said before, because neuromuscular conditions are such a wide spread of how people present, their problems that they have, etc. A lot of this research that goes into any of this is looking at your typical human, and they don't always think about people who actually have problems. So, and often I think people with particular conditions, including neuromuscular conditions, get overlooked. But Dominic might have some more information than me.
No, that's the gist of it, really. I think it would come in time. I mean, the way we deal with it, say in cystic fibrosis, where you've got to get enzymes to help digest food, you have a small capsule that's encased, gets through the stomach, but again, it requires people to be able to swallow. So at this stage, we don't have anything. I have to say, in the pediatric sphere, I mean, COVID doesn't have the same consequences in children that it does have in adults, and particularly people above a healthy weight of an older age. And so, for example, the antivirals are used sparingly in the pediatric sphere. Perhaps teenagers with predisposing conditions would get that, but really it's not part of the main thing of what we do in pediatrics, which is fortunate for our kids, and we can have those limited resources for adults where there's certainly good evidence that they are very helpful for mainstream people in taking the edge off the illness, reducing hospitalizations and deaths. So there's good evidence for that. So I certainly support them, think they are good, but it's not the be all and end all if you can't take them. And I think that's perhaps an emphasis. And I think there'll be more data that will come out in time, particularly when you take it in relation to your symptoms. And I think if you do all those other sort of things that Amanda and I have talked about, you reduce the risk. And it may be that even if you do get it, you may be like many people and be fortunate not to get it severely anyway. So I think we need to keep that in mind as well.
Yes, and I think that's been the reporting from a lot of members in our community, that, you know, that most people are faring okay with it. I think for me on a BiPAP, the hardest thing was having a stuffy nose and a cough when you're on the BiPAP. So actually the practical management of it, and also making sure that your care team is still able to come in and care for you if that's your only option. So yeah, there's just one more quick question. I know we're running late, but I'll just take this question from Sue Mon. She's asked, Amanda, are there studies on the prevalence of long COVID in patients, in MC patients? No studies you're aware of. And what's the impact on people's, you know, neuromuscular condition post long
Look,
COVID?
I don't think we know. And usually with the long COVID, a lot of the things are related to like fatigue, and people just feeling too tired to move about. So of course, with someone with a neuromuscular condition, it will depend on whether or not they're ambulatory, in a wheelchair, and probably will have the same impact. But again, I've been pleasantly and really happily surprised that how well the people that I know with neuromuscular conditions have actually handled COVID and gotten through. And none of our patients, which is only a small number, have actually complained of long COVID. In fact, they fared well, much better than other members in their family quite frequently. And I think it's because they're more vigilant. And also some of the people who are like ventilator dependent, all their air is being put through filters and things like that. So in some ways, they might be slightly protected, which we hadn't even sort of thought about. So, but we just don't have enough information at the moment. And as I said, the hard thing with COVID is it keeps changing. So the information we're getting now is about the variants that were a few months ago. And, at this particular point, we're sort of in a not too bad a spot in that we've got rid of, the flu numbers are down. The COVID variant that's out there at the moment, variants out there at the moment are fairly mild. We keep our fingers crossed that there's not too many changes.
Yeah. Thank you so much. Thank you. Could everyone please thank Amanda and Dominic for their time today? Thank you so much, guys. That's
Carolyn,
wonderful.
before you move on, there was one more technical question.
There was,
for
and I
Dr.
didn't-
Fitzgerald, but I will just send it as a
Yeah.
direct message to him for him to
That's
reply
great. I
back.
did want to, yeah, that's right. That
It
wasn't
was
more
from
of
Dr.
a
Addy in the UK, so I'll send
doctor
that through
question,
now.
and I thought that we might take that offline. Yeah, good idea. Thanks, Alicia. Thanks, everyone. Thanks.
Thank you.
Now we're going to move on to our next session. Moving right along, we've been talking about respiration. Now we're going to talk about bone health. So let's introduce our next two speakers. We have Professor Craig Munns, who's speaking to us today. He's the head of paediatrics in the Child Health Research Centre in the University of Queensland. He's a senior medical officer at the Department of Endocrinology at the Queensland Children's Hospital. He's got lots of jobs. Professor, you're very busy. Thank you for your time today. Your clinical and research interest is primarily in paediatric bone disorders, and you've published a lot on osteoporosis, which is certainly something that can affect people with neuromuscular conditions not being bone weight bearing. So yeah, I'd like to introduce Professor Munns, and then we'll go to Karen Herbert after your presentation. Thanks. Take it away, Professor Munns.
Thank you so much, and thank you for the opportunity to speak with you today. I'll just share my screen and yell if you can't see that. So so thank you so much for the opportunity to speak with you today. I'd just like to start by acknowledging the Indigenous and Torres Strait Islander people who are the traditional owners of the lands upon which we're all meeting. And knowing that we're in very many different parts of the nation today, and pay my respects to their ancestors and also their descendants. I think something that's really important to appreciate is that the Aboriginal Torres Strait Islander peoples whose lands we're meeting on today were in fact the first healthcare providers and educators in these lands, and we're in fact just trying to continue in the traditions that they started many, many years ago. So I've got no specific disclosures for this talk. So an outline, what I do, a case of recurrent fracture in a child with neuromuscular disorder, such a child with Duchenne muscular dystrophy. Talk about what makes bones strong, how to do a bone health assessment, quickly through what is osteoporosis specific for, as I see, children with neuromuscular disorders, and then at the end talk about monitoring, prevention and treatment options. So this is the case. So a boy who came to see me, who's now 11 years of age. He has Duchenne muscular dystrophy and he was diagnosed at 3 years of age and has been on daily deflazacort, which is an oral steroid, since 4 years of age. At the time of presentation, he was ambulant, but using a wheelchair for long distances. and he'd had a fracture of his distal femur or thigh bone, which you can see the arrow there pointing to the fracture just above his knee when he fell in the bathroom. And then at 7.5 years of age, so after that fracture, he was referred to me for assessment of his bone health. So the history, his mother was a single mother who had a very sore back. The house was unmodified, so there were no hoists. The bathroom hadn't been modified. There were no ramps. He had early contractions. He was pre-pubertal. As I said, he was walking around in the house but used a wheelchair for other mobility. He had a good dietary calcium intake and was on no special supplements. So the investigations we did, being doctors, we stuck him with a needle and did some blood tests. So we looked at his calcium homeostasis, so that's looking at his blood calcium level, phosphorus, which is very important for bone mineralization, alkaline phosphatase, which was a measure of bone turnover, a vitamin D level, which vitamin D helps absorb calcium from your diet and get it into the blood so it can go into your bones, and that was normal. Parathyroid hormone is the main hormone that controls your calcium metabolism. So the parathyroid glands sit in your neck. We looked at his thyroid function because thyroid is very important for bone metabolism. And it's also always important to make sure there's nothing else going on. And celiac screen. So celiac disease can affect anybody. So you want to make sure that even though you may have a neuromuscular disorder and you think that's probably the reason the bones are a bit dodgy, that you're not missing something like celiac disease. He had a bone density scan done, and we'll have a look in a bit more detail later about bone density, but a bone density is basically just a big X-ray that looks at the amount of calcium in the skeleton, in the body, and by that you can infer how much bone you've got. And his bone density Z scores, which compares him to a child of his age, were low, especially in the spine with -5. So you think a normal range is down to about -2. So his was really low. And he had evidence of vertebral compression fracture. And I'll say it now, and then I'll say it a little later on again as well. If there's one investigation I would do in anyone with a neuromuscular disorder to find out whether they've got bones that need treating, would be a lateral spine X-ray. Because if you've got vertebral compression fractures, by definition, you have osteoporosis. And it's cheap and it's easy to do. So he had evidence of vertebral compression fractures. So he was treated with a bisphosphonate called zeledronate. And again, I'll talk a little bit more about that later on. He was treated for 2 years, and you can see his bone density improved. And he had modeling out of his fracture of his leg. But as happens with a lot of kiddies, once they fracture and get a bit older, especially in Duchenne, they're no longer walking, so they lose ambulation. So because his bone density had normalized, we stopped treatment. And at the time, we weren't really sure how long we should be treating with a bisphosphonate for. So I had a long chat with the parents about what their options were and with the child about what his options were. And the decision was made to stop treating. So we kept monitoring him, and 18 months later, at the age of 11, his bone density had fallen a little bit, but was otherwise pretty good. Now, he came and saw me in clinic. And then that afternoon, I don't know if I jinxed him, but that afternoon, he sustained a further fracture of his distal femur with routine cares. And that poses the question, was it the best option to stop his treatment? So looking more generally at bones, bones are made to be strong. We talk about bone density, but bones aren't made to be heavy. We talk about bone mineral content, but bones aren't made to have lots of calcium in them. Bones are made to be strong. So what are the determinants of bone strength? The main two determinants are the size and the shape of the bone. And then sure, how much calcium there is and the material properties of the bone. So what the bone's made up of is very important. Now, this little slide and cartoon is meant to show how bones are made strong and the relationship between bone geometry, or the shape of the bone, and the bone strength. So the cartoon on the left has a diameter of 100%. Its bone density, its density is 100, cortical area is 100, and the cortical mass is 100%. Now on the right, all we've done is made the diameter 17% bigger. We haven't changed the density, we haven't changed the area, and we haven't changed the mass. All we've done is made it bigger. You can see by making it bigger and keeping everything else the same, we've actually made the cortex thinner. So it's wider, but thinner. But because we've made it wider and bigger, we've increased the strength by over 50%. So the best way that you can make bones strong is to make them big. And you think about that in everyday life. The difference between a twig and a log is the size of the twig, if you like. All a log is a big twig. You can't break it. They're all made of wood. So what we're trying to do is make the bones bigger, and that'll make them stronger. So what determines bone health or bone strength in children, and to that extent, adults? 80% of it is your genetics. So I don't mean do you have an underlying genetic disorder. It says if your parents have dodgy bones, then chances are you're going to have dodgy bones, because general bone strength is what we call a multi-genetic disorder, so polygenetic disorder, lots of little genes all working together to work out how strong your bones should be. So that makes up 80%. So what makes up the remaining 20%? It is muscle. Your muscle mass and the strength of your muscles determine 15% of the remainder. So if there's one thing that you need to do, so you know, if you're talking about children or adults, the one thing that you can get them to do to optimize their bone health is to make sure they stay active and as strong as possible. The remaining 5% is made up with things like vitamin D and calcium and nutrition, other lifestyle factors, your gonadal hormones, and we'll talk about medication in a second. But the greatest determinant is your muscle. And that's been shown really well in tennis players. So the tennis player on the right is the recently retired, what's his name? Roger? You know, some would say one of the greatest tennis players of all time. I would definitely say, from what I've seen, one of the nicest blokes of all time. And then the guy on the left is Rafael Nadal. Now, let's look at Rafael Nadal. Is he right-handed or left-handed? He's left-handed. And have a look at the size of the guns of his left arm. They are enormous. So there's a study being done in tennis play, or in racket sport players, where they've looked at the bone density of their playing arm compared to their non-playing arm. And these are the results here. So their playing arm is in orange and the non-playing arm is in blue. And it looks at the side-to-side differences in the bone density of the humerus, or the biggest arm bone. And T1, so Tanner 1, this is pubertal stage on the y-axis. No, x-axis. Which one's on the bottom? X. So you've got T1 is prepubertal, T2, you're just starting to go through puberty, all the way through to T5, which is when you're fully pubertal. And you can see if you're a tennis player, as you go through puberty and you're active, you make bone. So that leads to a simple equation that puberty plus exercise equals bone. Now, if you learn nothing else from today, that's all I know about bone is that one equation. So that's all you need to know to be a bone expert, is that one bit of knowledge, that puberty plus exercise equals bone. So what do we know about neuromuscular disorders and bone fragility? In a way, a neuromuscular disorder is the perfect storm for having bone fragility. You've got the neuromuscular related factors, and as we've talked about just now, muscle is very important. So you've got a progressive myopathy. You've got a loss of ambulation, and as with the boy who I talked about earlier, you are prone to frequent falls. Then you have glucocorticoid related factors. And the reason that that's there specifically in neuromuscular disorders is, as we're aware, that many neuromuscular disorders, most specifically Duchenne muscular dystrophy, is treated with high dose and prolonged glucocorticoids. And then there's other factors: delayed puberty, muscle plus exercise equals bone. Delayed puberty is often seen in people with neuromuscular disorders. And then to make bone, you get taller by making your bones bigger and longer. So if you've got growth deceleration, then you often have a low amount of bone as well. And you can see on this growth chart on the right that there's a growth chart of a child, and when they started the glucocorticoids, their growth fell right off. So what do we know about specific disorders and bone? There's not a great deal known. There's not great detail about every single neuromuscular disorder. We do know a little bit about spinal muscular atrophy and fracture. And this is a study that was published in 2017 of 85 children with neuromuscular disorders. And what if they, with spinal muscular atrophy. And in spinal muscular atrophy, there's three main types: SMA 1, 2, and 3. SMA 1 is the most severe, through to SMA 3, which is the most mild form. And it showed that the more severe your neuromuscular impairment, the younger age of your first fracture. Where, for example, in SMA 1, the first reported fracture was an average of just over 3 years, SMA 2, 7 years, and SMA 3, 10 years. And the majority of the fractures happen in the distal femur. And that's very common in children and adults where there is reduced mobility for whatever reason, be it a neuromuscular disorder, a spinal cord injury, cerebral palsy. The distal femur is a really common site of fracture. And we'll talk a little bit more about different types of bone density. But the other thing is that loss of ambulation or going off your feet was associated with reduction in bone density at just the site where you fracture. So as shown on a distal femur bone mineral density assessment. What about long bone fracture in Duchenne muscular dystrophy? Again, you can see the similarity of the type of fracture, and this time it's a boy with Duchenne muscular dystrophy. So up to 25% of boys with Duchenne will sustain a long bone fracture. And the risk of fracture increases with age and reduction in ambulation. Of those who sustain a long bone fracture, the majority are in the lower extremity. And up to 50% of boys who sustain a lower limb fracture never walk again. So that highlights the importance of maintaining bone integrity, and falls being the most common cause of fracture. Interestingly, glucocorticoid therapy didn't seem to be a risk factor, or doesn't seem to be a risk factor for long bone fracture in boys with Duchenne. That's a different story when you start to look at vertebral fracture. So a vertebral compression fracture is where and you can see here in the pictures, instead of being nice and square, there's this dip in the vertebra. So just imagine the top of that's just broken and squished down. So a vertebral compression fracture is just what it says. The vertebra compresses down. Vertebral compression fractures in boys with Duchenne is associated with glucocorticoid treatment, and it's far more common than long bone fractures, with up to 3/4 of boys with Duchenne having compression fractures. And the time from fracture, the time from starting glucocorticoids, so that's steroids, deflazacort or prednisone, to first fracture is about 3 years. And the longer you're on steroids, the greater your risk of sustaining a fracture. And the fractures can either be completely asymptomatic, or at least where the boy doesn't complain about it, or symptomatic. So fractures in Duchenne muscular dystrophy, muscle weakness, most likely associated with long bone fractures, steroids, most likely associated with just vertebral compression fractures. But there is no doubt that steroids do affect long bone strength, and there's no doubt that immobility impacts on the strength of your vertebra. So even though I've presented it quite sort of, didactically, steroids, vertebra, mobility, long bone, there's no doubt that there is that interaction.
Sorry to interrupt you, Craig. We have about less than 5 minutes left for your.
Sure.
Sorry.
So every single fracture in a child can be associated, should be thought of being associated with osteoporosis. So how do you assess fracture? It's important to take the history about mobility, puberty, nutrition. Think about the physical environment and fall risk. Think about puberty, examine puberty, even though it's a little embarrassing, make sure you do it. Blood tests we've talked about just now with vitamin D, puberty and thyroid function, and bone density. But in this cohort, doing bone density of the lateral distal femur is really important. And lateral distal femur is where you do a bone density just where the fractures occur. And in children with cerebral palsy and Duchenne, it has been shown that as your bone density reduces, your risk of fracture increases. So it's very important to be doing that. I talked about how I love lateral spine x-rays. Do a lateral spine x-ray, please, whether it's an x-ray or a VFA, which is a way of assessing it in using the bone density machine. So what are we trying to achieve in managing children with bone health problems? So we're trying to improve function, quality of life, reduce pain, reduce fracture risk, prevent long bone deformity, neurological complications, maximize inclusion, and in many cases, or some cases, prevent premature death. So the way to prevent, keep the children and adults as mobile for as long as possible. Make sure children go through puberty at the right time, minimize the amount of osteotoxic medicine like steroids that we're on, make sure there's adequate calcium and vitamin D, and then at the end you can have bisphosphonate therapy. And you've got to do that in an interdisciplinary team. So there are some data on bisphosphonates in children with Duchenne, and it's shown that bisphosphonates increase bone density by increasing the amount of bone. And there are some data to start to suggest that it may actually prevent developing vertebral compression fractures. So for the first time, we're starting to get some data to think that if you give bisphosphonates before a fracture, it might help prevent a fracture occurring. And there's also good data in boys to show that if you give them testosterone therapy, that your bone density will increase. So that means that you really need to start to think about giving testosterone to boys at about 13 or 14. So what should you do? People with neuromuscular disorders should have a bone density test every year. And if they're on steroids, a lateral spine x-ray every 1 to 2 years. If they're not, every 3 years or so. And at the early signs of osteoporosis, so that's compression fractures or a single fracture, start bisphosphonate therapy. And unlike what we did in the boy that I showed earlier, should stay on some form of bisphosphonate while they're on steroids. And then also think about inducing puberty at 13 to 14 years of age, whether it's a boy or a girl. And that's it.
Fantastic, Craig. Heaps of information. Thank you so much for presenting today and coming to us from a different time zone up in Queensland. Thank you so much. That was wonderful. And I think bone density testing is one of those things that we don't necessarily relate with neuromuscular conditions, but I know as an adult, you know, when I was sent off to the endocrinologist and I said, I'm not at risk of falls, I don't play sport, I won't get a fracture. What does, you know, what's the issue? And they said that, you know, with you know, not having good bone density, you can even get a fracture when you're just transferring or you're just, you know, moving around generally, and it doesn't have to be, you know, a bad fall to get a fracture. So it's a very important topic to get a hold of, and you know, right from children but up into adulthood as well. So I know that my local hospital, Royal North Shore, has a ceiling hoist that can help you get onto the bone density machine, because I think some of those practicalities are really difficult for people to actually even get those tests done. So yeah, so finding out where those kinds of good equipment is also a really good thing. But thank you so much, Craig. That's wonderful. I'm going to go straight to Karen, and then we'll come back with any other questions to do with bone health and falls prevention. So is that all right with you, Craig?
Absolutely.
Great, thank you. So I'd like to introduce Karen Herbert, who's a physiotherapist at Sydney Children's Hospital, and she'll be speaking with us today on falls prevention and management in both children and adults, because she has worked in both areas, and she's also worked in all sorts of countries around the world and in all sorts of settings. So I'd like to welcome you today, Karen, and we will need to keep the presentation short because we are running a little bit late, unfortunately. My emceeing skills are going down.
No problem, Karen. No problem, Karen. I'll keep it short and sweet. So this was a little bit daunting when I was asked to speak about this topic, because it's not primarily what I do, but when you reflect on it, it's what I do every day. My job is to prevent people from hurting themselves and falling, and also to keep them strong. And as Craig has just said, muscle mass is what we need. So I went to the literature, as we always do, and in the next couple of slides, you'll see that the risk of falls is multifactorial. And as previous speakers have spoken about, there are so many different neuromuscular conditions. So the papers are very varied and don't really give us any clear direction. They talk about people's difficulty accessing interventions, and they talk about the problems that happen in their day. So this might be more of the information part of your NIRD day today. And Carolyn helped me. I said, what do people want to know? What should I talk about? So she gave me some questions, and I've tried to answer those with a very practical basis, but based on evidence-based and research. Why is it not progressing? Help me. Here we go. Sorry, there we are. Got it to work. So there are several things that will affect your ability to operate, and how you operate within your day will affect your risk of falls. So medication is one of the major ones. Many people take medications either for their disease or for other conditions or issues that they have, and the doctors have spoken about several today. So we need to just be mindful that those drugs are not impairing you or affecting your ability to make decisions, or affecting your making you dizzy, or affecting your vision or your balance. So you need to be mindful when you speak to your GP or your neurologist if you've got anything that you think is actually affecting your ability to move during the day. Sight and hearing, very, very basic, but keep your glasses on if you need your glasses. Don't read your reading glasses if you're getting up to walk across the room, because you'll make errors in judgment, which will increase your risk of falls. So also hearing aids, you don't hear the dog coming along and over you go, you trip over the dog. You need to keep your hearing and your vision checked regularly, and you need to take the advice that you're given by your practitioners to keep yourself safe. This is wearing my OT hat, my home safety. So we know that people don't always want to have their houses modified. They don't want to have handrails, and they don't want to have to take things carefully. But
The risks really go up when you make yourself unstable. So it is good to have things assessed and make sure you can make your day easier. And we'll talk about that a little bit more in the next few slides. But actually taking that support can make the difference from success and failure in a day. And when we reduce your risk of falls, we reduce those risks and complications that Craig was talking about. And we also can try and keep you fit on an even playing field, as opposed to those dips when you get sick and then we have to build back up again and then we dip back down again. So avoid climbing ladders and climbing on chairs. Ask someone else to do it if you're not capable of doing it. Lighting, this is a really big one, especially if you're getting up at night to go to the bathroom. Make sure that you have a night light or a torch, or you turn the light on. Some people will use the sensor light, but that you use your vision so much in making judgments about depth perception and for keeping you safe when you are trying to mobilize. I think in 2022, most of us have a mobile phone with us, and so we just turn on our torch, but we can also use those for an alarm, but we'll talk a little bit more about that later. So trips and slip hazards. Now, you've probably heard about this so much in your working life if you're working, but we need to keep everything out of the way to reduce your risk of falling over, making sure that if you've got mats, they're tied down, make sure that if someone spilt juice on the floor, it gets wiped up. If the lino's lifting up, making sure someone comes in and taps it back down again. So we just need to think each day, has something changed? If someone else has come in and they've decided to do the cleaning or to tidy up the house for you, have they put things where you thought they were, or have they moved them? And this avoiding rushing, taking a few minutes just to think about what you're going to do, how you're going to do it, what's in the way. Do I have to move something out of the way before I can do that? Do I have my walking aid near me? Should I get up without it? Am I in a rush? The phone's ringing. Does it matter? No. Take your time, get there safely. Especially if you're outside and you've got uneven surfaces. So footwear, this is something that I talk a lot about in neuromuscular conditions. Many people have issues with their foot posture, their foot shape, may have orthoses, may have specialized footwear. You need to make sure that those are nice and sound, that you've got a good non-slip sole on the bottom, and that they're comfortable. You need to make sure that they're well maintained. So you need to talk to your health professional to make sure that they're comfortable, especially you have something like CMT. That's extremely important that we make sure that you have good foot health. And then the last one, which is probably what I talk about much more, exercise, and Craig has really given me a good inroad here. You need to keep active. And that's really what we're going to talk a little bit more in the next part of the presentation. Now, in the last 15 years, there's been a big move in neuromuscular conditions. It used to be felt that we shouldn't do any exercise in neuromuscular conditions, that would make things worse. There's been some excellent research which has identified what type of exercise should be done for what type of conditions and how that should be presented. And that's being explored even more, especially in the areas of like SMA, CMT has come out with something recently. Duchenne is very clear. There are very clear guidelines on all of these things. And that's why today I can't give you a general exercise plan. And that's why I would encourage you, with the benefits that we have from our government at the moment with the NDIS. I know it's not straightforward. I know it's difficult to fill in the paperwork. And I know there's a discrepancy if you're over 65. But we do have opportunities to take advice from health professionals who are skilled in this. So I think it's something that we should all consider. So life is a balancing act. How do we achieve everything that we want to do? How do I have time to do all the things that I want to do? How do I fit in this exercise that physio tells me I have to do when I want to be with my friends, and also I've got to go to work to earn some money? So you might have to consider doing things in a different way. And you might have to think that what you're doing today might not be the same as you did it a while ago. But you have to each time think about the safest way to do it. So I would encourage you to plan ahead, consider across the day. Also, maybe even consider across the week. You know, if it's Monday and you go too hard and you've got to work for 5 days, you're going to be in trouble. We talk a lot about pacing. That basically means you need to save some energy to complete the activities for later. Otherwise, later when you go to try and do the activity, you're not going to have so much strength. You're getting more fatigued and you're more likely to have a fall and to hurt yourself. You need to be kind to yourself. You need to give yourself some rest time to allow your muscles to have a break, and then they can start to work again rather than being completely worn out. So what if everything just seems too hard? you know, you haven't done much exercise for a while, and you know, everyone's suggesting that you should be, I would always say start small. Anyone can do something small. Just start with a very small goal that you hope to achieve in a short period of time, so that you can celebrate your effort. You can say to your carers or your friends or your family, hey, I did this. So I would encourage you to do this with a therapist, but you could do this with a friend or a family member. You just want to slowly increase your level of support. If you start too big, you're likely to become discouraged. So it might just be a few sit to stands. It might be an extra lap around the lounge. I do know a lady who went out to the washing line, and she just increased the number of laps to her washing line each day. Or it might be some arm activities, because we know that exercise is not just standing and walking. Upper limb and cardiovascular exercise is just as important. Some of the other presenters have touched on that today. So if you're transferring and you're transferring yourself, but you're not standing, your upper limbs and your upper body are just as important. And I'm seeing this very much with people who are in their chairs and not standing. They need good upper limb strength. So that's equally as important. So even having just a slight increase in activity can improve your cardiac and your strength, which will reduce your risk of falling. And previous presenters have agreed with me here. And that will also reduce your risk in transferring, as Carolyn mentioned, which is also just as important as falling when walking. You need to try and be consistent with your activity. And that's the hardest thing in activity across the board, all ages, disability, no disability. People start January 1st, they go off to Fitness First, and by February the 1st, they quit because they had too big a goals. We need to set goals that you can achieve, something that you can stick to. So what is the importance of a mobility device to independence? So a mobility device should be an enabler. They should make something easier, and they should allow you to do as many things as possible. If that's not working, you need to reconsider it. You need to think, when you're looking at a device, you need to think about it. Does it suit your needs? Is it too clunky? Is it too heavy? Can I get it in my car? Is the hand shape the right size? Is it too high? Is it adjustable? Is it easy for me to use it? Or is it just too awkward? I don't kind of understand how it works, or it just doesn't work for me. And really, it should increase your confidence and it should increase your safety. And you need to make sure it's well maintained. So anything that's got a rubber bung or ferrule on the bottom, you need to make sure you test those from time to time. Make sure someone checks that all the bolts and things are tied up nice and securely. Because if you're putting quite a bit of weight from that, you don't actually want that collapsing. That would increase your falls risk. So you need to just maintain any mobility devices that you're using for your independence. So different situations will call for a different level of assistance. So if you're inside your house, it's not the same as if you're going out with the family to the zoo for the day. So you need to consider the risk of falling, your energy level, your level of fitness, your level of fatigue when you're thinking about what you're going to do. All those things, along with your medication, your vision, and things we talked about earlier, will change your risk. So you think about that in terms of the environment, the time of the day, the level of assistance to be provided. If you're with a great family member who can take your arm when you're feeling a bit tired, that's a bit different to if you're going on your own off to something that's a little bit intimidating. So this is an analogy that I use with my colleagues sometimes. Mobility devices, we kind of try and help people understand that they're a means to an end. So sometimes we talk about a wheelchair or a power wheelchair as being like our taxi. So it will get us to where we want to go. So I want to go to the cafe and I'm not going to be able to walk there because it's too far. So I would take a taxi, but someone with a neuromuscular condition might go in their wheelchair. When they get there, they may park their wheelchair outside, like I would get out of my taxi. And then depending on the space in the cafe, I might walk in with my friend I've met holding their arms or using a stick or on my own. So when or if walking is becoming more difficult, using a wheelchair isn't the worst thing that can happen. It's something that allows you to do what you want to do. And doing that can make such a difference to your quality of life and in reducing your risk of falls. This is one of Carolyn's questions. How important is walking even when you have difficulties walking? Well, Craig just said it's really important to use your muscles. Yeah. Standing and walking really are usually the exercise that most of us have done. But when we're upright, we do take weight through our joints and muscles. We do stretch and use our muscles, and it does assist some of our body systems, and it maybe make us a little bit out of breath. But we must always consider safety. So if standing and walking is becoming more difficult for you, It may be something that you only do in therapy. It may be something that you only do with somebody with you. It may be something that you do in the pool. Standing and walking in the pool is a great activity and it gives you extra stability. It may be that you use a walking frame, or you may use some sort of other system with somebody in your therapy situation to keep you upright. You may use a standing frame. For some, walking is not going to be possible, so we might use other things like standing frames, or we might use resistance or Pilates reformer or something. And this is something that's being explored much more, especially in the area of SMA, where there's quite a lot of research about muscle and strengthening at the moment. So it is important to be standing if you can. It is important to walk if you can, but there's always that proviso, is you need to be safe. Because if you're not safe and you fall, you've got an extra problem, haven't you? You're in hospital. So if you do end up in hospital, how do you build up your mobility again? Well, I would say try and stay as active as possible as you can when you're in the hospital. So when that blessed physio comes around and she said, we've got to get up and we're going to go for a walk, and you say, oh no, I can't do it now, I'm too tired. Try and take those opportunities to exercise. Try and keep active in bed. I'd say, for my experience, neuromuscular patients, when they don't bring their splints into hospital, they leave hospital in a dreadful state because they have worse contractures. So don't forget to take your splints, or get someone to bring your splints in if you're staying in hospital, and wear them, because that will affect your base on the floor, and that will affect your stability, which will increase your falls risk. So try and stay as active as possible in every situation. And we come back to that being realistic again. If you haven't been exercising for a while, you need to start small. You can't just view that I'm going to get back to exactly where I was just before you went into hospital or whatever happened. You have to be starting where you are. So you're setting your long-term goal, which is where you were. Sure, absolutely fine. But start with those small challenges. Start with something in a bite-sized way that you can add on slowly, and that you can achieve, and you can see that you're achieving, so you can feel good about it, because it's very demoralizing, isn't it, when you can't achieve skills. So we want you to help with your motivation and your consistency by choosing goals that are smaller. I also find it's helpful to vary your activity. So not just lying on the bed doing your exercise, make something functional, or do something social, do something with a group of people, and just try and think with your therapist ways that you can be more motivated to do that activity. Will it have a negative effect on my walking when I use a mobility device when I'm out in the community? No. It won't, because it's safety, isn't it? It won't affect your walking. It will just at that point make it easier for you to walk in that situation. As I said before, in a different situation, you might not use that level of support. You might use a different level of support. That mobility device, when you're out in the community, may have a positive effect by increasing your safety, allowing you to complete and enjoy the activity, rather than worrying, am I going to catch my toe? Am I going to look, am I going to fall over? Or is this going to be too difficult and I'm going to have to go home early and I won't get to see someone later in the day? And it conserves your energy for later, so that you can enjoy the social part of your life, which is just as important as any other part.
We might need to start wrapping up, if that's okay.
Yep.
Karen. Really, really great.
Last two slides. So equipment. So there are some major changes in equipment. So we have wearable technology, things that can monitor body systems, and Apple phones, Apple watches. There's Google, and there's other technologies that people use that they might detect a fall and send an alert, and also to tell you if you're having some trouble. There's huge ranges of mobility aids. Don't think that they are all the same. They've changed quite a lot. We have wheelchairs. We have wheelchairs that we can add power onto, so they're not quite as big as a power wheelchair. And we have power assist. We have wheelchairs that can help us stand. And I know one of our young people later does use one. And there's a great variety of hoists to help us move from place, and hoists to get into a car. Ta-da! Finished.
Excellent, excellent. And sorry it was so rushed. We're running short on time, Karen, but such great information, and really great, some of those points to follow up with your own health practitioners, or your support coordinator, your OT, your physio. Yeah, really, really important stuff. And I think that message of starting small and just building up, that's really, really important, isn't it? And yeah, I just wrote in the chat, mobility devices can be amazing tools for independence, because I know so many people think and are so concerned about that, losing their independence from going in a wheelchair or using a scooter, and it's actually opens up people's worlds sometimes. So it's not something that you have to do all the time. It might be sometimes, like when you're on holidays or something like that. Yeah, thank you so much. We might take a couple of questions and then we need to go to our break. So thank you to you and to Craig. Craig, you're still there. That's great. There was a couple of questions in the chat. One of them was, do adults need more bone calcium to keep up bone density, say more than a person without a neuromuscular condition?
No.
No to calcium?
A short answer, no.
Okay, what about vitamin D?
No. So
Okay,
all you need is
only if
all
prescribed
you need
by a doctor.
is normal. So 1,000 units of, for an adult, 1,000 units of vitamin D per day, 1,000 milligrams of calcium, but without exercise, you won't make bone.
Right. Okay, good. Interesting. Excellent. And then the second one in there was from our friend Dr. Sanders in Melbourne. When do you think people should be referred to endocrinology or metabolic bone clinic versus management by a neurologist or a GP?
For their bone health?
Yeah.
So if the GP or neurologist is happy to monitor bone health with doing, assessing fracture, bone density and lateral spine x-ray, if they feel comfortable doing that, then there's only a need to refer once there's a fracture or there's a concern about low bone density, if they just need an opinion. But if it's just monitoring, then that can be done locally. But if you're worried, if you want advice on when to start treatment or what treatment to do, then that should be to an endocrinologist. But everybody should be referred to a physiotherapist, exercise physiologist or similar to make sure that you don't need a referral to an endocrinologist because you maintain your mobility. Yep.
And then just one more question, is weight bearing considered exercise? And I guess that's coming, from those of us who can't, it is difficult to proactively exercise when you have trouble moving.
Sure. So there's data in children with cerebral palsy showing that if you are in a standing frame, your bone density is better than if you're not in a standing frame. There are data on vibration plates in children with cerebral palsy showing that standing on a vibration plate does improve your bone health. So yes, it's better than nothing, but it's not as good as moving.
Mm-hmm.
And when people are standing in a standing frame, we don't usually stay static. We try and add some activity. It might be upper limb, it may be weight shift, which all uses your core and your co-contraction. So standing is never usually passive, even if you are in a standing frame. So it is something. It's, everybody can do the best that they can. And even standing in the water, you're actually moving quite a lot in the water using your muscles. Not as much as without the water, but if that's what's possible, then that's what we should be doing.
Yeah. And even like neck and hand and those kinds of exercises are really important, aren't they? Because they, obviously someone like myself can't get up and run the marathon, but we can do those kind of daily neck and hand exercises and feet manipulations and stretching and all those types of things. So
and those are the skills you want to maintain for your quality of life. So
yeah, so functional independence is
absolutely
really important. Yeah, excellent. Oh, so good, guys. Is there any more questions in the chat? Does anyone else have any questions? I think we probably need to break very soon, but I'd just like to do a round of applause. That'd be a very quiet one. But yeah, thank you so much, Professor Craig Munns from Queensland. Thank you so much for your excellent knowledge, and also for Karen Herbert from Sydney Kids Hospital. Thank you so much. We're going to break, guys. We're going to have a little 5-minute break. And we're actually excited to say that we've got a member of our community. He's a musician and he's able to play us through the break. So I'd just like to thank Rob Matthews, who's an active participant in our FSHD Friends peer group. He's actually played alongside AC/DC and Santana in his guitaring, which I'm just amazed about. And he's also won an ARIA award. So I'd just like to throw over to Rob to play us through our break. Now, what time will we be back? We will be back. It is now 3:04. We're having a 5-minute break. So 3:09 and we'll be starting at 3:10. So how about that, guys? We're going into our breakout rooms when we get back. And so you'll see up on the screen that you should be going into a breakout room and you should choose that. So that hopefully will work at 3:09 p.m. Thanks, everybody. There we go.
on music, but I can't sing.
Thank you so much, Rob. That was awesome. I'm going to come and see you live one night at a RSL near us. They'll be performing, I'm sure. So thank you so much, Rob. That's fantastic. We're going to kick straight into our next sessions now. I don't know if everyone's back yet from their break. It was only a quick break, but I'm going to introduce Robin Forbes. Oh, Robin's standing by. That's wonderful. Robin is a genetic counsellor from the Royal Hospital for Children in Melbourne, and she's now working at the Australian Neuromuscular Disease Registry. And you may recall Robin spoke to us last year. So thanks, Robin's coming back to update us on any changes that have occurred with the registry and let us all know about what we should be doing to keep our information in the system, and so that we can make sure we get data and use that for research and information purposes. Thank you, Robin.
Thank you so much. You make it very difficult for me following on from that break. So I'll be nowhere near as
You're not going to play your guitar today, Robin?
No, sorry. So I enjoyed that. So thank you. And thank you for the opportunity to speak today. So I'm hoping my screen is changing there. So just a very quick overview. The Australian Neuromuscular Disease Registry was re-established in 2019 to look at information on children and adults from all over Australia with neuromuscular conditions.
Robin, you're not sharing your slides.
Oh, I'm sorry. We'll go back.
But lovely to see you, Lauren.
Thanks, Lauren.
So why is that not working?
Have we made Robin a co-host, Alicia?
We tried it before and it worked.
Yes, yes, she is.
Yeah, it's working.
Got it now.
Got it? Great. Thank you. Thanks, Lauren, for that. So the Australian Neuromuscular Disease Registry collects information on children and adults from all over Australia with various neuromuscular conditions. For a few years, we collected information on people that had Duchenne, spinal muscular atrophy, FSHD, and myotonic dystrophy. And I'm absolutely thrilled to be here today to be able to say that with the support of Muscular Dystrophy New South Wales, and this is really exciting, that we've been able to add the congenital muscular dystrophies, the congenital myopathies, and the limb-girdle muscular dystrophies to the registry. So a very sincere thanks from our team to allow us to be able to do that. So why is that important? So at the moment, we have over 600 patients on the registry. We have colour-coded the conditions here. And the new
Robin, there's just feedback from the audience. Can you make your screens a little bigger by making the slideshow bigger for it? There we go. Thank you so much.
So we've only added the new conditions. We have ethics approval to add those conditions, and they've only been added since about the middle of this year. So hopefully after today and talking to the group today, we're starting to spread the word, and we're going to increase these other rare and neuromuscular conditions on the registry. So why an Australian registry? And essentially it's the data on the registry, we hope, will help us facilitate best practice care and service provision within a national context. So we will know where people are around Australia with a neuromuscular condition. And it's going to help us understand the landscape of the various neuromuscular diseases throughout Australia. And in rare diseases, no one country is enough. And the registry is a part of the Treat NMD Global Registry Network. So the questions that we're asking and the information that we're asking is kept completely confidential, but it's the same as the registries in the UK are asking, in Europe, in the States, in Canada. So by collaborating together, hopefully we get information much faster for our community. The registry also aims to provide a platform to support and accelerate neuromuscular disease translational research. And that translational research means that we move what's happening in the laboratories and in the research area and with pharma into clinical trials and potential treatments and therapies in our neuromuscular community. By knowing where people are around Australia, the aim is to become clinical trial ready. And so we know where you are, we have baseline information on people, we have genetic confirmation of your diagnosis, but I think we're moving very quickly in the neuromuscular space to become treatment ready. And with the advent of disease-modifying therapies, the registry is a resource for post-exposure safety and efficacy monitoring. And that means that once the new therapies have been approved and being used, such as we have in the SMA space, that the registry is an independent way of following up on how well those treatments and those therapies are working, and are they doing what we thought they would do when that treatment was in a clinical trial space. So please don't take a screenshot of this. We've actually made this up, and it's just a slide to show you where the registry data can be used. So what happens is laboratories and academic institutions and research institutions will have a basic idea about a potential treatment or therapy. We've just picked out here a whole lot of drugs and treatments that are potentially going to become available in the Duchenne space, just to show this as an example. And when we get to this point here, so when a drug or a potential therapy becomes an investigational new drug, the registry is contacted at this point in time by some of the pharma companies, and we'll be asked a question, for example, like how many boys are in Australia that have a particular mutation, that are steroid naive and are ambulant. And that information may help a clinical trial come to Australia. The data that we provide is aggregate, so we do not give information of where people are within Australia, but we would just respond to that by saying 10. So aggregate data means that data is pulled together no personal information is passed on to pharma whatsoever. We just respond to that question. And hopefully that helps different treatments and therapies coming to Australia. The other place where the registry data we hope is helpful is further along over here. So clinical trials are done. We see if these treatments work the way that pharma and the doctors think they're going to work. And then at this point over here, where a new drug application occurs. And this is where a pharmacy company will apply to the government for approval for drug use and for reimbursement for drug use. And the pharmacy companies have to go before a committee called PBAC, and PBAC makes decisions about whether or not treatments and therapies can be used and for what reason they can be used and if they can be reimbursed. And PBAC asks us for registry data here. And this is why when you're on the registry and we ask you questions like what was the outcome of your last 6-minute walk test or your CHOP in 10 score and all these fancy names for the measurements that the physiotherapists are doing, this information, again, completely de-identified, aggregate form, completely confidential, is used to show that in the real world setting, that these therapies are making a change. So the registry model, the way that we work, we have an advisory committee. And am I allowed to say anything here, Carolyn? Just give me a nod. So we've just recently invited Carolyn to be our consumer representative on our advisory committee, and she has agreed, which we're quite excited about. So patients can contact us to be on the registry through our webpage, and I'll show that at the end of the talk, or a clinician may mention this to a patient, or clinicians and clinics may have our flyer in their clinic and patients can find out about the registry. Patients contact us, informed consent is obtained, and then the registry staff will chase up the demographic, the clinical data, chase your genetic results if you don't have them, and then we record your functional outcome measures. So that's the assessments that the physios and the OTs and the respiratory doctors and the cardiologists all perform, and the data is updated annually. If you don't have that information, don't worry, we can work with you in trying to chase that up, but it's important information that we record. So it's a prospective registry, which means that new patients, we hope, will go on the registry, and as patients hear about the registry, they go on. And the registry can serve a couple of purposes: that we can record the natural history of the disease and the condition. So that means how a disease normally progresses without therapies or treatment, but particularly important for respiratory and motor function. The registry can help monitor and measure the effects in changes of treatment, and that's going to be really important in the neuromuscular arena moving forward. We can help assess the quality of life in Australia for individuals living with neuromuscular conditions, and hopefully we can help facilitate patients' access to clinical trials and to different types of research. So why a registry now? Why are we adding more conditions now? And I think the landscape for neuromuscular conditions is changing very rapidly. Registry data can help aid our understanding about the natural history in 2022 and beyond, and how best to monitor and treat the various neuromuscular conditions. And there are standards of care for different conditions such as Duchenne and spinal muscular atrophy, but these standards of care are changing as treatments become available, so that we can be clinical trial ready for when different therapies come up, and that we can help accelerate the development of new therapies. We do share anonymised data, as I said, with the global registry. We can respond to registry inquiries, and anonymised data, we hope, will bring different trials to Australia. I thought we may get 1 or 2 inquiries a year, and we're actually getting about 5 inquiries a year. So I think that's quite exciting. And then we can link clinicians and patients to clinical trial sites. So the sites that are doing the different trials and the specialists in those areas that are doing the trials, and hopefully help facilitate that process. And then, as I mentioned, the registry data can be used for post-marketing surveillance, the real world evidence. We hope that patients will consider going on the registry, that give me a call, we can have a chat with the registry team. You don't have to be on the registry. Being on the registry or not being on the registry does not mean that you queue jump to get into clinical trials, but at least if we know about you, hopefully we can help facilitate that process. If you feel that the registry isn't right for you, that does not impact on your care by your local team in any way, shape or form. Registry fatigue. We know that being on the registry, that we contact you once a year to update your information. People are busy. If you're a parent with a child or a couple of children with a neuromuscular condition, you have a lot on. An adult with a neuromuscular condition, we understand you have a lot on. So we appreciate that we chase you up once a year, we ask for your time, and we appreciate all of the effort that our 620 registrants put into the registry. So I think the registry hopefully can help inform the new neuromuscular disease trajectory that we're rapidly approaching. And we are, as I said, we are incredibly grateful to MD New South Wales for helping us get these other rarer conditions onto the registry. And we know that high quality and reliable data is going to be essential to help us look at the new disease modifying therapies that are available. And the registry
just
data,
2 minutes, if that's okay, Robin.
yep,
Sorry to
absolutely. So the registry data can help identify potential outcome variations of treatment. So what happens in the real world when you're no longer in a clinical trial, and we can respond with rapid updates as this evidence becomes available. We can inform the scientific, the clinical and health policy communities when it comes to neuromuscular conditions. And the registry is a powerful tool to observe the course of neuromuscular conditions outside a clinical trial setting. And that was that example I used as a phase 4. We can be used as a research tool, and hopefully our data will help inform the standards of care and the new standards of care. But I think importantly, the registry can help you, that we want to support patient advocacy. So don't forget that we're here and to use us to aid you in supporting patient advocacy. This is what our registry webpage looks like. So please consider having a look at that. And you just hit the link and one of our team will get back to you. And then this is the way that you can contact us. So thank you very much.
Oh, excellent, Robin. Thank you so much. That's really great. And as I said before, it's really our best chance of collecting, you know, that data and not just in Australia, but across the world, so that it can be used for trials and research and you know, and the breakthroughs in treating neuromuscular conditions. So thank you so much for your time, Robin. And we're going to, is there any, no, I don't think there's any questions, but there was a couple of bits of feedback. There's a couple of people joining up the registry, Robin, you'll be happy to know. And it is a good process. It's you know, it is something extra to do, but it's really people there are lovely to talk to. So I think I encourage everybody to join the registry. Yeah, thanks, Robin. We're going to go into our breakout sessions. We're going to organise that now. Everyone has chosen their breakout session, but there are some people who haven't chosen a breakout session. Is that right, Alicia?
That's right. So you should see them there now. So just select the one that you signed up to when registering, or if you didn't, just choose whichever one you want to go to now and it'll take you over to the room. Can everyone see the breakout rooms? Great.
I can just see a list of people that haven't joined one, but
I think that's because you're a co-host.
right. Yeah.
Carolyn, what will be the timing of the breakout rooms?
Good question. We're going to do 35 minutes for the breakout rooms, Joan. So we need to just cut that back a little bit. But so 35 minutes from now will be 5. That's 4 o'clock. Yeah, no, they're not coming up, Alicia.
They're not coming up?
No.
Oh.
There they are. Yep, they're good now. So
I can't see the breakout room.
Okay, sorry, let me try again.
Unless I'm doing something wrong.
There's so many buttons to press. We don't know which button sometimes, do we? Yeah, so it's not giving you an option on the breakout at the bottom of the screen, Alicia.
Yeah, I know. Sorry, it's just
Right.
I've just had to close them and now there's a countdown of 20 seconds before it's letting me reopen
Oh,
them.
so this is where we do a singing a song, or we do a joke, or
it's not helping our it's not helping our delay. I'm just going to pause.
I think everyone's coming back in. Everyone's coming back in from their very short feeling breakout sessions. I'm sorry that we had to cut those short, guys, and you probably got booted out mid conversation. But topics. Are you right, Michelle?
Yeah, just we did end very abruptly, but I just wanted to say thank you to Sarah Grace because I didn't get a chance, but also to say that if anyone in our session had questions, please contact us.